This echo is from a 59-year-old man who has come with a history of dizziness. And look at this. He has a structure in his left atrium, and if I can describe it, the echogenicity of this structure is that it's a mixed echogenicity. It's like tissue, okay? And if you look at it, you can see a little bit of an attachment to the interatrial septum. It is almost completely occluding the left atrium. And although the mitral valve itself is opening normally, the left ventricular inflow tract is almost completely occluded by this mass. But however, remember that the echo itself is a two-dimensional echo, so we don't know whether the entire LV inflow tract is occluded. I'm sure that he was otherwise well, and therefore he's clearly getting a preload going into the left ventricle. But in this section, it's almost completely occluding the left ventricular inflow tract. Okay, and that's just another close-up of that mass. These two images, and see how. And the interesting thing is, during diastole, the mass is actually prolapsing into the left ventricle. Okay, see how it is prolapsing into the left ventricle, and it's actually crossing that. And the effect of that is, it's not only causing an obstruction to left ventricular inflow, but during systole, okay, during left ventricular systole, you have the mitral valve is unable to close, and as a result of that, you have an eccentric. I'm just going to go slowly. You have, see, look at this. Sorry, that's the R. No, that's actually okay. Initially, I thought that this was actually some mitral regurgitation coming back. Okay, but the color of this is red, which means the red is, if you look at the color coding here, red is going towards the probe, towards the transducer, which means that this is actually the inflow. So this is pulmonary venous inflow going from the pulmonary vein into the left atrium and then into the left ventricle. And when I froze it, I don't think I could see much of a regurgitation. So it's mainly causing an obstruction to the left ventricular inflow, and the flow is going it's just going, bypassing this mass and going around this mass to enter the left ventricle. Okay. Now for people who are doing advanced echocardiography, you'll have to do Dopplers as well, and what you find is that the pulse wave Doppler is giving you the velocity at the level of the left ventricular inflow. That's actually not too bad. Okay, that's no problems. However, if you look at the mean gradient that you measure across the aortic valve by continuous wave, this is actually measuring the entire flow across the left ventricular inflow tract, not just the mitral valve, and that shows values of roughly about, the mean gradient is about 10. Now, if you didn't know anything else, you would say that this patient has mitral stenosis, but that's not the true story. What this patient has is an increased turbulent flow due to a partially occlusive left atrial mass, and the most likely pathology is going to be a left atrial myxoma, because you could see the stalk attached to the to the interatrial septum. And finally, the same patient also has a bicuspid aortic valve, and you can see that the left and the right coronary cusps are both fused, and they are both quite sclerotic, not calcific yet, and the non-coronary cusp is the one that is opening well, and that is what is maintaining the aortic valve opening. But in a few years' time, my expectation is that he will have moderate to severe aortic stenosis. So one of the things that the cardiologist and the cardiac surgeon should have to think about will be if they're going in for operating on this left atrial myxoma, then should they just do an aortic valve replacement at the same time, even if the patient does not have severe aortic stenosis at the present time?